So, Roy, obviously very exciting data we're talking about, but it seems to me, as we do with most things, we want to potentially move this into the first-line setting. Give us your thoughts about use in the first line. I know we have a number of clinical trials ongoing, so on and so forth.
Yeah, certainly, the idea of bringing immunotherapy to the frontline setting, that's, I think where the drugs are really going to differentiate themselves. And if we could use an immunotherapy and have results like we're seeing in the second line, perhaps even greater, and not have the side effects of chemotherapy, that would be wonderful. So what's happening now is all the different agents that are under study, and a number of PD-L1 agents, a number of PD-1 agents are moving to the frontline setting. There are a number of different trial designs right now. Generally, most groups are using whatever biomarker they've chosen, to select the higher response group. Those are being used to select patients in the front line. So I'm very partial to trials that are looking at chemotherapy versus a PD-1 or PD-L1 agent with some biomarker selection. Now, of course, each of the groups has different biomarker selection.
Right.
The other approach, of course, is combination with chemotherapy.
Right.
And of course, that's what we do, right?
Right.
Now, will that be better or not? How does that play? So you might give chemotherapy, you might give the PD-1 or PD-L1 agent, you might give an angiogenesis inhibitor, maybe bevacizumab. Some data are mixed. There's some data, with nivolumab that don't look so exciting. Actually, Naiyer can probably comment better than I. He presented some of that. And then there's the data with the atezolizumab, which looks rather exciting. But I would caution, having done this long enough, I'm sure you've seen the same, you can always get high response rates with selected patients in a phase 2 trial with chemotherapy plus a drug. I'm particularly intrigued by combining bevacizumab with the atezolizumab or the chemotherapy, because I do think that the angiogenesis inhibitor might traffic more T cells into the tumor. I think we need a little bit more data on that, but there are some randomized trials ongoing there as well. But the promise of having this drug perhaps available to 30% perhaps of people in the frontline setting is huge. And then for those that do not have the right profile, then we need to think of combinations. The other thing about the biopsies in the frontline is there's less variability because you've gotten the biopsy now much more close to the time that you're treating, because it's first line and there's been no prior treatment.
Yeah. Naiyer, any comments?
Yeah, I think we don't really know what the potentially deleterious effects are in terms of chemotherapy on your T cells, your immune system, and whether you're harming it in some way. So I think the first line data will be really important. We were part of both the nivolumab and the pembrolizumab sort of first line experiences, and if you look at the waterfall for the pembrolizumab, for example, there was very few patients that didn't have some level of tumor regression. So I think that there are, I think there's no question there's going to be a subset of patients that will be positioned to get single agent first line therapy. And I think, and again, as we come back to the biomarker, I think that's probably where it's going to be most useful. And as you know, I mean, there are randomized trials in PD-L1 positive patients with PD-1, versus chemotherapy. And it's hard. I think that those trials will be very useful when they read out to help make that decision. So the other piece in first line is the combination immunotherapy with CTLA-4 and PD-1 or CTLA-4 and PD-L1. We've seen the data in melanoma, which showed clear superiority with combination immunotherapy, both in PD-L1 positive as well as negative patients. And so if you've got lung cancer and half of the patients are PD-L1 negative, you want to do more for those. Maybe those patients are less mutated, have lower levels of PD-L1. Can we drive greater immune recognition and T cell response with the CTLA-4, PD-1, or PD-L1 combo, because the CTLA-4 does more priming of T cells within lymph nodes, whereas the PD-1, PD-L1 does more activation within the tumor microenvironment. So it makes sense to combine them. And certainly the preliminary data, does look like you can get some reasonable activity in both positives and negatives. The data with the MEDI 4736 and tremelimumab showed about 30% response whether you're PD-L1 or negative. So that, the combination as well as the nivolumab, ipilimumab combination are both in phase 3s now, is first-line combination versus single-agent immunotherapy versus chemotherapy. So I think we're going to, we're just starting to really figure this out, and I think we're going to learn a lot as we go along.
But I think your point, at least to me, the use of a biomarker is critically important in first line. It's like the EGFR story. If you use EGFR TKIs in the mutant population first line, it's much better than standard chemo.
So I got to say, once the biomarker catches on first line, you wonder if it might catch on all sorts of places.
Well, then the question is, independent of biomarker, other than the usual exclusion criteria, knowing what we know about the 2 checkmate trials, where in squamous the biomarker didn't make a difference, and in the non-squamous, even if you were biomarker negative, you weren't worse than chemo. I'm going to ask you guys about toxicity in a second, but if you had this disease in second, third line setting, non-squamous, which drug would you rather get, docetaxel or nivolumab?
I think that the answer is is nivolumab. I think that what I would caution people though is that the patients who respond are a subset. Okay, so it's 20% of patients. So there's this desire out there to grasp pseudoprogression, as a huge deal, and they don't want to come off the immunotherapy. The doctors don't want to take them on in case they're having pseudoprogression. Patients don't want to come off. And so I think it occurs so infrequently in lung cancer patients. I'd hate to see patients be on immunotherapy for too long and then not get to
Standard
third-line
therapy,
chemotherapy.
Yeah.
Which can work for a long time for the right people as well.
Right.
Right.
Good point.
Right. So